Well, let me clarify too. I think we're hammering on this patient that can't walk, but I think this is such a huge point of friction. It's worth talking about a lot. But the patient that can't walk, I mean, is there ever anything that's uncovered in their hospital admission that maybe we're missing in the ER? Because I guess that's maybe my conception is I see the patient that can't walk. Their workup is negative. There's really nothing acute that I can find in the ER. And at that point, I'm like, oh, I'm done. They can't walk. I admit them. Is there, and with the caveat that maybe there's nothing, they need placement somewhere. But sometimes I look at that as like, okay, well, this is the dispo. They're admitted they can't walk. Is there ever anything major uncovered that we're missing in the ER? Because maybe that's my fears. I'm like, maybe there's something else going on and they'll uncover and be able to fix. Is that common, or is that much more the exception than the rule that there's actually something treatable?
I think that so first of all, to your point, thank you. Because I think that on our side of things, we suffer a lot from the selection bias of all we hear is the number of people who are getting admitted because they either can't walk, or let's just widen the aperture on that too. They're pre-syncopal. They had maybe a questionable syncopal episode. There's a total body debility or weakness kind of thing going on. And I think we miss the full denominator, and it's helpful to hear that those processes are going on. But on those cases that have to come to us, I think I would say it's uncommon that we discover something that you all have not on your clinical exam, biochemical assessment, imaging studies. They happen. Absolutely, they happen. They will happen multiple times today, multiple times this week. On balance, I think the plurality is we don't find much new. Yeah. Don't let that influence your practice, do your workup. I absolutely will continue to do our workup. But I think that's part of the dissatisfaction on our side of things that comes with these admissions is no fault of your own or our own, but gravity, time on this planet. Yeah. It is continuous, it is progressive, and it can make these people and lifestyle decisions, let's be clear, and opportunity to access care in the outpatient setting, socioeconomic factors here. It's a whole set of issues that go into this, but by and large, I don't think we're finding things much more exotic or interesting than you all haven't picked up on. You have good instincts down there. You have a pretty good meter for something's wrong or not wrong, sick or not sick. It happens, but it's I would say it's less than half the cases.
Yeah. Well, what I'm taking from this is a point that I think no acute findings on the workup, patient can't walk does not have to equal admission. If I don't think there's something else going on that I just haven't uncovered, I think we probably could do a better job of trying to figure out another viable solution. And social work is available quite a few hours. I mean, maybe we just need to involve, they always want to be involved more. Yeah. They're always telling us they want to be involved more, and maybe we can do a better job of involving them at all hours and say, can you go talk to this family and provide them with, this is what a hospital admission could do for you. Maybe that's not anything they couldn't do at home. Yep. Because social work seems to have this much more comprehensive understanding of insurance and what facilities are available and what they can take, what they can't take, what's going to be out of pocket. Because we don't understand any of that stuff. Right. But they seem to have a very good understanding of it. In a very short amount of time, they can look at the patient's chart and make these determinations and see past interactions with this patient, which are very common, and say, hey, they've refused rehab in the past, so an admission, they're going to be here for 24 hours to find out they don't want any of the solutions we may have for them.
I think it's worth saying in this conversation, and I don't believe anybody here is saying this or claiming this, but I don't think anybody's considered this the patient's fault. Right. This is just kind of where they are, and they are looking for help. Yeah. We have a very, you mentioned it, imperfect system at play for these cases that don't need a workup inpatient necessarily. There's not a lot that medicine and biochemical sciences and procedures can offer them, but they still need help. And I think that culturally, the United States of America is one of those places where children of aging parents move out of the home, not always in the same city. They are pursuing careers, that capitalist mentality that we have, go west, young man, right? Or whatever it happens to be. And do your thing. That's not every patient's families, but we don't have a lot of the cultural backstops that maybe our other Homo sapiens in the Far East or in Europe have, where there's multiple generations in a home and that support is present. It's, I'm going to miss work, what I have to do, and I have to justify being off and away from the office or from my job to take care of mom or dad. and my kids need to be in 2 or 3 sports, or I need to, be at that chess club, whatever it is. Part of this, I think, is just culturally some of the challenges that go with being who we are as Americans. And there's, I think, an interesting conversation being catalyzed right now around the terrible events in New York City with the United Healthcare CEO about claims, about what we care for, what we don't care for in this country. And, maybe there's an opportunity here to improve all that. But for the time being, this is the system we have.
Mm-hmm. Yeah, I mean, certainly, a lot of these cases, an OBS admission is probably inevitable, but I think we can probably do a better job of presenting the patient with their options, and what an admission can accomplish and what it can't. So that's one thing that will change about my practice a little bit from this conversation, will be a lower threshold maybe to involve social work early in this, especially when you see the patient and there's going to be nothing acute found. You can make the phone call at that point. You don't have to wait 2 hours until everything's back. Yep. Social work can come and talk to the family, because I just find that they are so much more well-versed. I'm not really even equipped to have that conversation and tell them what an admission would accomplish for them versus what going home could accomplish, but social work is, and I think that would be a better stopgap maybe to avoid some of these admissions that cause so much friction between us.
I agree. We need those case managers and social workers so badly, and I think one of the reasons that it's a subtrack in the hospital medicine provider's mind during this admission conversation is because every day we sit down for probably about an hour per unit. So every doc is sitting down for about an hour in our multidisciplinary rounds and hearing, they have this insurance, so they can't get this. They have that insurance, so they can't get that. They have this insurance, which is going to take 5 days. Mm-hmm. And so we are reminded of these shortcomings on a daily basis every day across all of our patients. It's a facet of our care. It has to be. It's important because it influences what we do for that patient when they leave. And we are frustrated for the patient. We are frustrated for the system by virtue of the reimbursement structure and the care structure that we have here.
Yeah. Right. And we all want the best thing for the patient, but the patient may really prefer to wait on some of these options for themselves at home. They may not want to sit in the hospital bed for that. And so I think allowing them to make that decision. And then too, when we've done some of the groundwork, I can say, hey, Sean, social work has seen this patient. They don't have any good options for them. Family can't take them home. And then the groundwork is already laid. And I feel like then I would be less likely to use the verbiage of selling an admission and be like, hey, this is an appropriate admission in my mind now. It's not something I have to grab your arm and force you into doing. It's something where we've done the groundwork. And it would have the benefit of maybe that patient's in the ER for a couple more hours to wait for social work. But if we are increasing throughput in the entire hospital, then our other admits are going to go directly up to a bed. Right. They're not going to be sitting in the ER.
Yeah, these days in our
it will have
system,
downstream
we
effects.
have to think about the downstream effects. 10 years ago, 5 years ago in this city, we didn't have to as much. You add 200,000 people to the population and no extra hospitals, we as ER providers have to think about that trickle-down effect a little bit more too. Not just for our own impact, but the entire system. It's just the way it is. It's just overwhelmed. And I think all our specialists, I appreciate you saying that you appreciated me telling you the denominator, because honestly, if all our specialists, if our cardiologists knew how many chest pain patients we discharged today before we called with this chest pain, I think they'd be like, you tried. Instead of, really? Another? Yes, another one. Out of 20 today, I've called you on 1 or 2. Yeah, it helps to know, right? We should, but to keep that attitude and that collegiality amongst us, our responsibility in the ER is to do our darndest to not say this equals admission until proven otherwise. That's all.
And it just gives us the option to give the patient more options. We do that with chest pain patients all the time. Your heart score is kind of right on the border. I could see this being admission. I could see this being an outpatient cardiology follow-up. And you have that discussion with the patient. You don't have to talk with cardiology. You don't have to talk with internal medicine. The patient decides, you know what, I'm feeling a lot better. I'm okay following up. And we can document that we had that shared decision-making with the patient, and they can go home versus an admission. And, if their family's really worried, they're still symptomatic, then maybe we talk to internal medicine and admit them. But we give patients those options all the time where there's 2 options that are equally viable. And I think in those patients that don't walk, that's kind of the situation we're in. There's 2 options, inpatient versus, trying to handle this at home, and they're both viable options. If we just provide them with those options and exactly what they look like, which social work can provide, I think then they can use accurate information to make that decision for themselves. But I think can't walk equaling admission is maybe one of the misconceptions we have. Because I'm guilty of that all the time. Oh, patient can't walk, done deal. They need to be admitted.
Yeah.
Especially when it's, the old person that this is kind of a chronic deterioration. I mean, we get so many of these patients. I think that's why it's a huge talking point.
Absolutely.
And it's only going to go up
with that population growth, et cetera, and the aging population. I think this comes down to each hospital medicine group within a range has to sort of self-police or establish its own culture. At what point are we going to say, look, this patient doesn't have a safe option? If that were my grandmother, if that were my grandfather, and the ER had taken the steps that you had and the patient just felt uncomfortable going home, how would I want to see my grandfather treated? Right. And I think that this will ebb and flow, and different groups will have different cultures. I think all our group's culture is probably quite wide in this regard. And we could probably do with a little bit of an internal dialogue about, is this just kind of part of our job and what we do? And we trust our ER providers to have made these offers, to have suggested these things, made overtures to the social work and case manager team. And then the people we're taking is a numerator for us, but it's not the denominator for the whole emergency department.
Mm-hmm. That should be a conversation we should have too. How many of us are actually putting in the extra little bit of footwork on a busy shift for that kind of patient? Because we should. So that should be something.
And we're so focused on efficiency, but it does have those downstream effects are not insignificant either. Taking a little bit more time now is going to make your shift maybe a little easier tomorrow when the patient you do admit goes immediately up to their bed and they're not sitting in the ER for hours.
Something that's unfair for, I think, the gentlemen and ladies in your department is closure. We kind of hear the story up front relayed by you. We see the process and we have closure and a discharge or a transfer. And I don't know how much closure you guys get on these patients, if any. And so that sort of element of it went the way I thought it was going to go or not the way it was going to go, to your question earlier, how much of these admissions for trouble walking do you actually find anything?
Right.
And I think it underscores the point.
Yeah, absolutely. I mean, our ignorance of the outcomes of these if we saw the outcomes of all these patients, we'd probably make some different decisions.
That's probably true.
Because in my mind, magically, you're going to fix this patient. They're going to be walking. Or you have this magic way to get them immediately in a nursing facility, and you just wave this magic wand, and 2 days later, they're all set up in a nursing home. And that's just not the reality. And so I think correcting our ignorance of that would actually go a long way toward changing our upfront care.
I think the first time that I heard from a hospitalist, it's just unfortunate. I really am not going to have anything to offer them over the next 24 to 48 hours. The first time I think I blatantly heard that was only within the last year and a half, and I've been doing this for a lot longer than that. And I went, oh gosh, what am I missing? And that conversation was exceptionally helpful. I think it was one of our well-seniored in your group who kind of just broke down over the phone kindly and was like, these cases, this is how this is going to go. This is what I don't have to offer. We're going to end up in the same space 48 hours from now with a bill and these options, and kind of broke down how frequently these cases look that way. What have I done in the last 48 hours, and how the hell am I going to get them up to wherever they need to go now? Just like when we started this conversation from the ER. And I was like, oh gosh, I don't have a fix. You don't have a fix, but there's got to be a better way for me to start the process. If I can't end the process, there's got to be a better way for you guys to make progress. What do we do with this? It's just an eye-opener. Sometimes neither of us are going to have an answer, and the answer is, well, here we are back at the beginning of the conversation, and I know I'll get them a bed upstairs and figure out where we're going to go. But it was incredibly helpful to realize that there's no magic wand.
And another big friction point is to the demented patients too that are maybe more altered off their baseline. That's another big one too, where families they usually know their name and their date of birth, and they keep getting the year wrong on their date of birth today, and they're so much more confused than normal. And that's another one. We scan their head, we get all the lab work, we check their urine, everything looks fine, and sometimes it's usually the family. I think in those cases, a lot of times pushing for admission, they're not comfortable taking the patient home. I've had some where the hospitalist has pushed back, rightly so. The patient's demented, family's like, we're not taking them home. Family doesn't really have the right to say, we're not going to care for this patient.
Those are the ones I don't call hospitalists anymore. I call social work. And I go, here's what family's telling me, and I'm telling them that's not really how this works, so you're going to have to come back to me on this. Because I think you got to have some gumption as an ER provider at that point. If you're certain to say, which I do all the time, I know I'm a minimalist, but this is one I don't have any qualms about. The case that appears to me, after all the years of experience dealing with older folks, this is progression of your natural process, so where you want to go when it gets worse tomorrow or the next week, because you're going to have to declare it at home. There's nothing I can do for this right here, right now. Well, I'm not taking them home. All right, well, I'm telling you I don't have any other options. I'm not trying to be mean, and I will actually talk to the people that help me find other options, and they may tell you the same thing. I will go to all lengths to say, I can tell you now this is progression of where you're at. You've reset a new baseline. It may wax and wane for a few days, weeks, or months. This may be where you're at now and heading the other direction. Doesn't make it emergent. Doesn't mean I have a wand to put you somewhere, get you resources that don't exist. We should be pushing that a little further in confidence. Not falling back, and I don't know that we do, but not falling back on the whole, well, it is new and different today. I think I should probably just admit them because I still don't know. There are plenty of times I think in the back of our mind, we know this is the case that's not going to have something new discovered over the next 24 to 48 hours in this hospital. We got to have the balls to go, this won't be fixed today. This is where we're at in life. Now, how do you want to handle this thing?
Right.
Because I know that ER is the catch-all, and this is the smart place to start in case we found that thing, and we did not. What do you want to do now?
And what's the D-dimer?
Yeah.
I can talk to you right now.
I never order a D-dimer when I work with Adam. I don't
Well,
even
you're pretty
know
good
when
about
I
it,
should
yeah.
be ordering it when I work with them. I don't
That's
know.
I'll
I
teach you again
just
next
don't
week.
order
It's
it.
all right.
And we, I think that we started this conversation by acknowledging how one of the shared, I think, characteristics of our fields are being problem solvers. Different emphasis on other things, features within problem solving. Yeah. And we want to solve these problems for our patients and for our community. We're motivated to do that. But in a lot of ways, we just don't do a good job. I don't want to get too philosophical here, but talking about normal aging in our world.
Very true.
I think the latest Avengers movies has Harrison Ford in his 80s turning into the Hulk and beating the heck out of the enemy, whoever that happens to be. We don't do a good job talking about aging in our society and what normal aging can and should look like. And most importantly, how we preserve our patients' dignity and sense of self in that process.
That's true too.
Being hospitalized, God forbid, having to have wrist restraints placed or be pharmaceutically restrained. I think most folks, if they could be in a chair looking at themselves, would say, this is not how I envision aging. I envisioned myself as Harrison Ford turning into the Red Hulk and taking the smack out of bad guys. So, but that's not a problem I think we solve in the hospital, but maybe it's something we solve with conversations like this and the way we talk to our own families and our own loved ones.
Right.
I mean, it is deeply philosophical, and of course that would be a huge soapbox for everybody here and everybody else in medicine. But on that same exact vein, this is America, right? We could live forever. We got to be inches away from finding that magic fountain of youth.
Telomere expanding device or whatever.
We're gonna put those right back on there, and you're gonna keep on kicking. We're just gonna dust off those genes and keep going. We are scared to death of death on the whole in this country, and isn't anybody gonna get out of life alive here? And I think with a little bit of couth and tact, we could do a lot better job, even in it from an ER moment, of letting people know this might be where this is going, the inevitable that I know you all are scared of, but understand is going to happen one day. This may be one step closer to it. That is not something we can just fix with an admission or otherwise. And, at some point, each individual out there not in medicine has to own up to the fact that whether you're scared of death or not, it's coming. And one day, maybe that day you're sitting in the ER for 3 hours with no new answers, is the day you took one step closer. There is definitely no magic wand for that.
Yeah, and what
and
provides
it's okay
them
to
the most dignity as they,
That's
enter
it.
that
How
place.
do we make you more comfortable and proud of what you'd see?
When I was a paramedic, you show up on scene. And DNR is there, signed, and families like, nope, we don't care about this document.
That's right.
And you're like, listen, the things we're about to do to your poor loved one is not going to be dignifying. With no chance of anything. It's families aren't to blame. They don't necessarily understand that what the things we're going to do are really not going to be changing anything, especially in these cardiac arrests. But real quick, can you clarify an OBS versus an inpatient admission? I think that's a point that we don't have the best grasp of. My default often is to click OBS because I know you can change it to inpatient versus if I click inpatient, you can't change it to an OBS. Obviously, we get pushback on what our length of stays are. You guys get pushback from the system on how many OBS admissions you're doing versus inpatient admission. So we can help you out by hopefully doing less OBS admissions. Can you kind of clarify the difference between the two?
First thing I'll say is that even with a very concerted effort on my end, there is a lot of lore around what these different titles of admissions mean. I think from our perspective that the care rendered in the hospital does not change if you are obs versus inpatient. There's not some unlock that occurs when suddenly you're inpatient. Where it matters really is in metrics, in billing, and then in the opportunity for follow-on care, such as placement at a facility or something like that. In observation stay, the framing for that should be, this is a medical issue or issues that could probably be addressed in an outpatient ambulatory setting if somebody had unfettered access to their primary care doctor and specialists. That's kind of the framing. So we're not really talking about patients who have new unclear sources of hypoxia or low oxygen, right? We're not really talking people who have massive swings in their electrolytes or end organ injury. We're talking about typically things that could be reasonably addressed with outpatient resources and acumen. If somebody just had ready access over the course of a day or two to all their primary providers. Inpatient, the assumption is that that is not the case. There is some resource in the hospital space that could only be rendered for this patient's benefit by virtue of being in this hospital. It just so happens that with an observation stay, we're going to do all the kind of ambulatory plus things in an inpatient bed. Some folks will say that there is a length of time associated with, if you're going to meet 2 midnights, that should be an inpatient stay. But grandma who falls on a Friday night and is here until Monday or Tuesday morning, but everything is fine, and the admission diagnosis, the principal diagnosis is fall, and we add on a secondary diagnosis of hyponatremia at 134 because our lab says 136 is normal. Observation stay for 4 days. That patient will receive an adjusted bill in the mail for that their insurance company did not provide. Now, in many cases, it's Medicare, and it doesn't end up being a huge financial burden to the patient or family. But with commercial insurances, it absolutely is. And then with placement to a facility, if somebody has been, and this is one of the challenges, either inpatient or has met 2 midnights of an observation stay, it will count. So I think that every time I try to get a perfect rubric for this, it's a Venn diagram of different conflicting things. Mm-hmm. But I think that's a good general framing, is obs versus inpatient. I will tell you that every day on a list of anywhere from 14 to 18, I saw 14 to 18 patients every day the last 7 days I was on rounds, 2 or 3 pages from our utilization managers about changing the status, either to an inpatient situation based on something found, a PE, a stroke, whatever it happened to be, or because I assessed the patient, they were put in under inpatient, there was nothing found, and I actually was able to discharge them the following day. Can we downgrade it? Can we change the status to observation? So there are switches that occur in the hospital. It is imperfect from you guys because you don't have the full picture oftentimes, right? So when making the best guess, that's how I would frame things. Is this something that if somebody had unfettered access to their outpatient folks, they would be able to have worked up and completed? Okay. If not, where there's a resource that would only be available here to figure this out or solve, inpatient status is a good place to start.
It was interesting. About a year ago, there was a few months span where I would randomly and not infrequently get a text, maybe once or twice a week, from a random administrator somewhere who I'd never seen their name show up in the EHR's chat. Hey, the criteria you admitted under that diagnosis should go under OBS. Do you mind if I change it? Sure, whoever you are. Magic, admission, fairy.
Right.
Or that should be inpatient actually based on the criteria. Do you mind if I change it? Sure. And I would just say yes because I don't know who you are, but you clearly know something I don't know. And then it just stopped. No, I haven't seen that in a year.
I imagine Sean's getting all those messages now.
Like, I don't know. Yeah, maybe it's y'all.
They're coming to us. And when we go through our admission order set, we have the ability to change the admission status that you guys start with.
Okay.
I would say that's done a very minority of the time. Okay. No, we don't have a lot of things that we're changing. I think if you use the framing I laid out, you're going to be in good stead. Yeah. The reality is that some of our patients at one of our hospitals that we all know of can have a different patient population that's perhaps more worried well, and we just want to make sure this person's going to be okay. And are you sure we can't admit him for a night? I think that explains more of the observation stays at that facility than necessarily any misrepresentation or underappreciation of the diagnoses at play.
Okay. That's a good framework for how I haven't heard it explained that way before, but that makes some sense. Before I let you guys go, is there anything else you guys wanted to touch on or you came today wanting to talk about as we kind of wrap up?
I only wanted to talk about what you wanted to talk about.
Well, thanks.
Yeah, you're the boss.
I'll share I'll share an awesome book I recently read. It was kind of my book of the year for the end of 2024. It's called Same as Ever by Morgan Housel. I noticed that we have a lot of awesome books here behind us. And maybe it's higher behind me here, but
no, I have not read that one.
It's a great point of it's a guide to what never changes. And I think one of the anecdotes that's put into the book, which is the guy's a fantastic storyteller, but one of the awesome anecdotes that's put into the book is more or less, how bad news comes all at once and good news tends to be slow and compounding. And the case given is that with respect to heart disease, we've gotten about 1% better every year since the 1950s. And that's not going to make a headline. You're never going to hear about that. We get 1% better at our clinical care and management in the ER over time, over decades. And no one's going to read that article that's on the front of the New York Times. Hey, we're 1% better at heart disease this year, 1% better at strokes this year. But when that compounds over 20 or 30, 40 years, which is the legacy we've inherited from the docs before us, the APPs before us, and the legacy we're going to pass on to the next person, we're talking about saving tens of millions of more people every year in this country. And that's something that I think deserves the headline that you'll hear about. So that's just one anecdote from the book. But if you want something that's looking like a little more positive for the future and kind of where we are and how things are going and how some things aren't changing, but we don't necessarily see them in real time, Same as Ever by Morgan Housel. I just really enjoyed that anecdote recently.
Very cool. I'll just share a good patient experience I had the other day. I had a patient in our kind of fast track part of the ER, pretty benign complaint that we see a lot. I don't want to be too specific since it was fairly recent, but got some routine ultrasound imaging. Turns out this patient has cancer and we're finding it pretty early. We do a pan scan. There's no metastases. We have a great specialist that happens to be rounding on her patients up at this hospital, and she was able to come see him in the fast track. Somebody that, if we're super busy, is totally appropriate to send outpatient, by the way. But we had the time. I'm like, let's do the pan scan, make sure it hasn't spread anywhere, get these weird labs I've never heard of that she wants, that she was kind enough to explain to me how it manages her care. And next day she gets to excise this body part with the cancer at really, minimal risk to the patient at all. And, problem solved really because it hadn't spread anywhere. And that was just a good, I felt good, I didn't have a physician see this patient at all. I did it all, just as a PA, which feels good, and find the cancer, get it excised the next day, and patient had a great outcome. So that just, things like that make me feel good about my job sometimes.
Book the win.
Hold on to those,
for sure.
Man.
Not an emergent diagnosis. It's really not even
sometimes
something that we're
best.
equipped to always find. But, thanks to a great specialist that happened to be close by and had the OR schedule pulled up, it was a cool patient outcome, something that could be dealt with quickly, which I don't think we always get to do. So, anything else you guys have before we wrap up?
Yeah, I've been off for 6 days, and I'm thinking about how can I become a stay-at-home dad. That's that.
There's an app for that somewhere.
Gotta be something somewhere.
I'm hoping as life progresses, I can become slowly at least more time as a stay-at-home dad as opposed to at work.
Yeah.
But
I'm working for time, not things.
Yeah.
Yep.
Well, thanks you guys so much for your time. I think this is a
you.
great conversation.
Always.
That'll benefit a lot of people and change my practice a little bit too, which is unique. So
Good deal.
cool.
Good to
Thanks,
be here,
guys.
gentlemen. Thank you.
You too.